Karim, let me give you a brief update of where we are with the pandemic, where Africa's CDC is with respect to supporting member states, and lastly, to give you an update on the overall, at a much higher level, panoramic view of where we are with vaccinations on the continent. As of 9 a.m. East African time today, the African Union member states have reported the following. The total number of cases across 55 member states as of this morning stands at 3.9 million cases of COVID-19, and that represents 3.4% total cases globally. As usual, the recovery rate continues to be impressive. 89% of the individuals or people that have been infected have recovered. That is about 3.5 million total. In terms of deaths, we have recorded as a continent 104,000 deaths, and that represents a case fatality ratio of 2.7%. This is troubling because our case fatality ratio has increased or continues to increase compared to the global case fatality ratio, which stands at 2.2%. In terms of the number of countries that are in Africa that are reporting the highest caseloads, they include South Africa with 1.5 million cases, Morocco with 480,000 cases, Tunisia 235,000 cases, Egypt 184,000 cases, and Ethiopia 160,000 cases. There are, as we speak, 38% of our member states, or 21 countries, are reporting a case fatality ratio that is over 2.2%. Remember, the 2.2% is the global average, and we always use that as a benchmark. Let me now segue to the variants. 13 member states have reported the presence of the 501YV1 variant, in other words, the lineage B117. And these countries include Algeria, the DRC, Gabon, Gambia, Ghana, Kenya, Libya, Morocco, Nigeria, Rwanda, Senegal, South Africa, and Tunisia. 11 member states have reported the presence of the 501YV2 variant, or the lineage B1351. They include Botswana, the Comoros, DRC, the Gambia, Ghana, Kenya, Malawi, Mozambique, Rwanda, South Africa, and Zambia. You recognize that, as I said last week, Africa CDC takes exception in attributing a variant to a country because we have not done that with the virus itself, so there is absolutely no rationale in attributing variants to countries of origin. So we will continue to stick with the nomenclature. In terms of the trends that we have observed across the continent for the past 1 week, that is week 8, we have which spans between February 22nd and February 28th. If you compare that with week 7, last week, we have the following observations. First of all, we have recorded 68,000 new cases across the continent, and this represents a 9% decrease from the previous week when we met at the same time. The highest proportion of new cases are seen from Southern Africa, representing 35%. And by region, we also observed the following: North Africa, 25%, West Africa, 16%, East Africa, 18%, and Central Africa, 7%. The following 5 countries are reporting the highest number of new cases. South Africa, 9,500 cases. Ethiopia, 6,200 cases. Tunisia, 4,700 cases. Egypt, 4,200 cases. And Zambia, 4,000 cases. We now look at the deaths. A total of 2,300 new deaths were reported over the period of the last week, and this represents a 15% decrease from the previous week. Now, let's see the trends over the last 4 weeks. So if you look at the period between the 1st and 28th of February, we recognize that there have been an overall 15% average decrease in new cases across the continent over the last 4 weeks. And the trends by, the trend by region are as follows. 23% decrease in Southern Africa, 16% decrease in Western Africa, 11% decrease in Northern Africa. However, we are observing a 14% increase in Central Africa and a 7% increase in East Africa. If you plot the graph in East Africa, you take all the countries together, it will seem to suggest that we might as well be seeing the start of a third wave in Eastern Africa, if I take all the countries together and box them, but not disaggregating them by countries. So in terms of deaths over the last 4 weeks again, we have observed an 18% average decrease in new deaths across the continent. And the breakdown of the deaths by the most populous countries include a 25% decrease in South Africa, 18% decrease in DR Congo, 1% decrease in Egypt, however, a 37% increase in Ethiopia, an increase of 26% in Kenya, and 10% average increase in Nigeria. Let us now look at the testing. As a continent, as of 1st of March, 35 million cases of COVID-19 have been conducted across the continent with a positivity rate of 11.2%. Over 750,000 new tests were reported over the last week. This represents a slight decrease of 3% if you compare that to the previous week. Our team continues to mobilize in the spirit of the partnership to accelerate COVID testing to supply 19.2 million antigen tests across all member states. As we have discussed on this forum over and over, we believe that the antigen testing will be a game changer because of the simplicity to implement, the ability to conduct the test in more severely restricted areas in terms of geography and in terms of training people. The Africa CDC has continues to work with UNICEF to procure additional molecular testing, that is the so-called PCR testing. Over 300,000 of those tests will continue to be distributed. So we are not abandoning our major test, which is a molecular test. We are just supplementing that with other tests. In terms of other capacity, we now have trained through the Institute of Workforce Development over 11,000 clinicians and equipping them with the ability to the latest information on case management of patients across the continent. We have also, in the last week, begin training of healthcare workers on vaccination, and that will be in partnership with the Project Hope from the US and Brown University, where just last week we trained over 150 clinicians and AP managers in Ethiopia and South Africa. And such training will continue in the coming weeks, especially with the Francophone speaking African countries. Let me just conclude by expanding on the vaccine activities. As you've all heard last week, this week was I'll call it a tipping point in what we have been expecting, where many countries started receiving vaccines from the COVAX facility, and we are extremely appreciative of that. These include Nigeria, DRC, the Republic of Kenya, Cote d'Ivoire, Angola, Republic of Rwanda took delivery of their first COVAX vaccines, and this list is perhaps not exhaustive because, as we speak, there is an accelerated move to begin to distribute the first doses of the vaccines. What we plan to do next week is to have an extensive catalog of what exactly the number of doses that each country is receiving, so that we can discuss that more openly. But for this week, we have some numbers, but it's still premature to be putting out numbers there. As the vaccines are distributed, as we have discussed on this forum again, we have a simple formula that says vaccine plus vaccination equals life saved. So yes, we are having vaccines. We now have to focus on the vaccine delivery. And as such, Africa CDC, as you know, has launched what we call the African Vaccine Delivery Alliance, in abbreviation AVDA. And this is really similar to the consortium that Professor Karim is chairing. Is co-chaired by our colleague, Dr. Yodi, based in Nigeria, and myself. And the whole purpose is really what we call a coalition of the willing, to come together, bring all our assets together so that we can deliver vaccines and support countries across the entire continent in the areas of setting up vaccine centers, in the areas of cold chain delivery, in the areas of training at scale, and in the areas of logistics, overall logistics of supply chain management. So that is what that alliance is meant to do. And you heard last week when we announced that the European Union had committed 100 million euro to supporting us, and we are in the process of finalizing a work plan on how to use the 100 million euro to support this alliance so that we can make sure that the vaccines, once they come in, they are rolled out, you get the finality is getting that needle into somebody's arm, and then we can tick the box and we know that that person is protected, and not just protecting him or herself, but protecting their loved ones. Another, along the spirit of good news, you also heard last week that the United States Food and Drug Administration issued an emergency authorization use for the Johnson & Johnson vaccine, which is a single-dose vaccine. And the African Regulatory Task Force, which we are co-leading, will be reviewing the vaccine for its use on the continent as well. And we had earlier issued guidance on how these vaccines will be introduced on the continent. We will be hosting a 2 days conference, high-level conference, chaired by His Excellency Musa Faki Mohammed, the chairperson of the African Union Commission, President Cyril Ramaphosa in his capacity as champion for COVID, and His Excellency Felix Tshisekedi, who is the current chair of the African Union, on April 12, where we bring all stakeholders together to discuss a framework on vaccine manufacturing on the continent. We'll be looking at three things. One is, how do we support manufacturing on the continent so that by the end of the year or in 1 year's time, manufacturers begin to produce COVID vaccines. And that will be a comprehensive meeting with all stakeholders, not just within the continent, but outside of the continent, including donors as well. Secondly, will be to use the COVID pandemic and crisis to strengthen our overall manufacturing across the continent so that we do not get ourselves into this scenario where we scramble for vaccines on the continent. And thirdly, how do we establish centers or hubs of excellence across the continent so that it can get involved in research and development for vaccines? So, colleagues, let me at this point conclude this, and I will let we will go forward and do Professor Slim Karim so that we finish the COVID section, and then we'll do the Ebola briefing last, so that there is some align with the COVID story. So over to you, Wayne.
Very right there. It does make sense for us to finish one topic before we move on to the next. So now we invite Professor Salim Abdul Karim. I have already introduced him, and Dr. John has also said something about the great work that he's doing. So without much further ado, let me invite Professor Abdul Karim to address us. Prof, you have the floor.
Thank you very much, Win, and thank you very much, John. It's a great pleasure and an honor to be with you here this morning. I will be sharing my slides. I'm just checking if you can see my slide.
Yes, we can,
Okay.
Prof. Yes.
Wonderful. So let me just start by acknowledging the good work of the African CDC. And I don't say so because of my good friend John Kengasong, but because I've been at the coalface and I've been able to personally witness the hard work and dedication that has really enabled us across the continent to respond appropriately to this pandemic. So what I want to do in the next 10 to 12 minutes is I'm going to tell you quickly about epidemic trends and about variants. And let me start off with, what's the situation in the world? Well, we all got a surprise that in the middle of January, on the 11th of January, the epidemic started declining at a global level. And we saw for the first time ever in this entire epidemic, almost a year to the day, that the epidemic showed a consistent decline from the 11th of January to the 18th of February. And over those 5 weeks, the epidemic at a global level declined by just over half. So that's quite a steep decline and a consistent decline. Unfortunately, it's sort of not staying that way. It's now trying to decide whether it wants to stay flat or go up. And we'll keep a very beady eye on that. And I'll talk about this decline because it's really a very significant decline, because we've seen declines before, but those have been declines for a week. But a 5-week decline in this way, well, the first is to recognize that the pandemic is a mosaic of country epidemics. And you can see that in the way in which the countries are colored differently in the slide on the right-hand side. And you can see that our continent has been much less affected compared to North, South America, or Europe or Asia. But you can see that at the far end of Southeast Asia, that those colors match much of what we see in Africa. So we have seen a global decline over 5 weeks. Well, when you look at that decline, you want to understand what are the drivers of that decline. Well, the drivers of that decline are principally the declines we have seen in the US and in Europe. And the reason why we're seeing those declines, I'll come to in a minute, but essentially countries in North America and in Europe are now completing their winter second waves. If you look at, how are we in Africa contributing to the global pandemic? Well, I have to say, thankfully, a very small contribution. If you look very carefully, you'll see Africa right at the bottom, above March 1st, 2021. So we make a very small contribution to the global pandemic, and we have a minimal impact on the global pandemic numbers and the global pandemic trajectory. And let's look at, so why are we seeing this decline? Well, if we look at Africa, we've contributed in a little way to that decline because we've seen our own decline, and that decline that we are seeing is being influenced by South Africa largely. And you've already heard the numbers, so I won't go through it. Professor Nkengasong has outlined very clearly where we are in the global pandemic. So let's go on to the 4 key reasons why COVID-19 cases decline so that we understand what we are observing in the global trajectory. So the first is that if you take the population, there's a subgroup, a small subgroup of people who are those who are most at risk. So those are the individuals who move around a lot. Those are individuals who may not be following the rules. Those are individuals in high-risk occupations. So those individuals who are most at risk, they tend to get infected quickly when the epidemic is increasing. And once they've been infected, they are now immune. Now, we haven't reached herd immunity. Herd immunity requires a much higher level, but we are saturating with the natural immunity those who are most at risk. And so they don't get infected again, so we start seeing the numbers decline. The second is, of course, the impact of government interventions, that when you reduce the movement of people and gatherings, you decrease viral transmission. That's very clearly seen in South Africa, that when you look at when the government imposed restrictions in December, exactly 10 days later, our epidemic starts to decline, as you would expect in relation to the incubation period. And so you see the impact after the incubation period. Then we see an increase in protective behaviors during the waves. That when we have the cases going up, people become aware. And the whole issue of cases, people who are sick, people who are dying, becomes personal. The issues become personal. Somebody in your family, somebody you work with, somebody you know well. And so what happens is that we see an increase in protective behaviors. So it's a combination of people getting in, the most at risk becoming infected and immune. It's government interventions. It's about protective behaviors and people taking protection personally. And then finally, it's the cyclic nature of the waves. And we see that very clearly in South Africa. If you look at our first wave, which is sort of more like an African Mount Kilimanjaro number of cases, and you can see the hospital admissions in the gray bars. If you compare that to our second wave, which was driven by the 501YB2 variant, you can see how the cases rose much faster and to a much higher level, akin more to like a Mount Everest than a Mount Kilimanjaro. And you can see that it wasn't just that the cases rose, the number of hospitalizations rose dramatically. It put a huge amount of pressure on the healthcare system in South Africa. And as a result, deaths go up. So we have now recovered from the second wave. The cases have declined for the reasons I've just outlined. And we are now in a situation of low transmission. And the government has eased restrictions and we are back to level 1, which is the lowest level of the restrictions that we have in place. So that's where we are in South Africa. I'm going to talk very briefly now about variants, because this picture that you see in our second wave is a picture of the impact of the 501YB2 variant. So what do we know? Well, globally, there are 3 variants of concern. The first is called the B117, and that was first described in the UK. It has lots of mutations, 23, but importantly has this one key mutation in the receptor binding domain, in that part of the virus that attaches to the human cell. Then you have the 501YB2 variant we described from South Africa in December. And there, the difference is that this variant has 3 mutations in that key part of the virus that attaches to the human cell. And then more recently, we've seen from Manaus in Brazil, the description of the P1 variant, which has more mutations and also has the same 3 key mutations in the receptor binding domain. So globally, we have these 3 variants of concern. The one I'm going to talk about is the one in the middle, the one that we know is present in South Africa and indeed is now occurring in other countries as well. So what do we know? Is it more transmissible? Is the virus spreading faster? Well, let's just look at one province in South Africa. If we look at the Western Cape and you look at its first wave in the light green line, you can get some idea of what the wave looked like. Compare that to the second wave, driven largely by the variant. You can see that the cases rose much faster, higher, and then from the peak declined quite rapidly as well. So if you compare the two, it took the Western Cape 50% faster to reach 100,000 cases in the second wave, 54 days, compared to the first wave, 107 days. Now, there are many caveats to just drawing a simple comparison, but it gives you some idea of what the difference is. Our colleagues from the London School of Tropical Medicine and Hygiene have done a modeling analysis, and they find similarly that the variant is 50% faster in the way in which it's transmitted. So the variant spreads faster. So what do we know about whether it escapes immunity? So this is a bit of a challenge because we want to know, can you get reinfected? If you were infected in South Africa's first wave with the previous variants of the virus, are you protected against this new variant? Well, just serendipitously, a vaccine trial that was being done in South Africa had 31% of its participants had past infection. And they measured the attack rate. And what they show is an attack rate of 3.9%. And it was the same whether you had past infection or you didn't have past infection. This is the first empiric evidence we have to show that past infection provides only minimal protection against this variant. And it's been confirmed by a range of laboratory studies. Penny Moore's group, based at the NICD in Johannesburg, and Alex Segal's group, based here, they're just one floor above me, their labs have shown that when you look at convalescent serum from South Africans who were infected in the first wave, you get... I'm just waiting for James to mute himself. You get high levels of immune escape with the 501YV2 variant. So it looks like that protection from the first wave is not provided against this new variant. But as you might have heard yesterday, our scientists have found that if you do get infected with this variant, that it stimulates very good immunity against itself. And so you would be well protected against getting this virus. And because of its cross immunity with many of the other variants, it also does well in preventing the previous variants. So what do we know about vaccines? How do these variants impact vaccines? Well, if we look at the B117 variant, there's minimal impact. You see slight declines in neutralization, and there are different assays that are used. I won't bore you with those details. But if we look at the 501YV2 variant, and I've here listed the 8 vaccines for which we have clinical data of efficacy, but not all of them we've got evidence yet of how their immune neutralization is impacted. But we can see that for the 501YV2, we have differing levels at which the vaccine immunity that's in the blood of vaccinees, we look at how well can they kill this 501YV2 variant. And what we find is that the activity of their antibodies is lower. Now, what does that mean? It's not very clear. It's still under deliberation as to what these mean. But let's look at clinical efficacy. Does the variant impact how effective it is? And we only at this point have evidence from 3 vaccines. And on 2 of them, we only have evidence for mild disease. We only have evidence on mild and severe disease for 1 vaccine, and that's the Johnson & Johnson vaccine. Well, if we look for mild disease, we see for AstraZeneca that the vaccine is 70% efficacious in the UK and Brazil, but only 22% effective in South Africa in the midst of the 501YV2 variant. Similarly, the Novavax vaccine was 89% effective in the UK, but 49% effective against the 501YV2 in South Africa. Johnson & Johnson showed a much smaller decline from 72% in the US to 57% in South Africa. We don't yet have clinical data for the other vaccines, and it's unlikely we're going to be getting clinical data because it's not practical. These studies take so long to do that we're unlikely to see clinical evidence from them. So we're going to have to look at correlates of protection to understand whether these vaccines are being impacted. So one of the key things that we need to be thinking about is how to prepare for the next variants and vaccines. And there are many things we can do, including improving our surveillance for these variants. And I'm very pleased that the African CDC has taken this on. Actually, they initiated the network of laboratories in Africa to do phylogenetic surveillance even before we knew about the variants. And we know that we've got teams like Happy in Nigeria and Tulio in South Africa, and they've all come together to help us ensure in Africa that we are monitoring what our variants look like. And that will give us important information so that we understand what we're dealing with in the virus. And then, of course, there's certain things we need to do. We need to be creating repositories. We need to be developing the capacity to produce vaccines reactively. And now almost every company is making a new vaccine. We already heard Moderna's is already made and sent for clinical testing. These new vaccines are based on the 501YV2 variant, because they will then produce more robust responses against this variant. We know that Pfizer is making them, Johnson & Johnson, AstraZeneca, they're all making this next version of their vaccine to deal with the variants. And of course, importantly, that the variants are created because of viral replication. Every time that a virus makes a copy of itself, it increases the chance of creating a variant. Variants are created when the virus makes a copy of itself. So when the virus is making lots of copies of itself, the chances of a variant are much higher. So we want to suppress that. We want to keep viral replication. We want to keep the number of copies of the virus being made low as possible. And the way to do that is to suppress viral replication. In other words, reduce the number of people getting infected. And so we need to do that with all the tools that we have. Our prevention measures, such as social distancing and masks and so on. And importantly, the rollout of vaccines, because the vaccines are part and parcel of how we can impact on the transmission of this virus. Remembering that even though we are seeing diminished neutralization capacity of these vaccines, and even though we're seeing lower levels of effectiveness against mild disease, it seems that these vaccines still remain quite effective in preventing severe disease and hospitalization. And that's why it's really important that we continue our efforts to roll out vaccines and to achieve global equity in vaccine distribution. Thank you very much.
Thank you very, very much, Prof, for that very comprehensive briefing. And I'm sure you've answered a lot of questions that people had in their minds. Now, let me invite Dr. Merawi Arago of the Africa CDC, who's going to give us a short briefing on the Ebola epidemic in the DRC and in Guinea. Dr. Merawi, good morning.
Good morning. Thank you, Madam Minita. Good morning, colleagues. So I will just give you a brief overview of epidemiology of the current ongoing Ebola outbreak in 2 countries. So as of today, March 4th, a total of 28 cases, Ebola cases have been reported in 2 member states in DR Congo and the Republic of Guinea. A total of 12 deaths have been reported, resulting in a case fatality ratio of 43%. This represents 64% increase in the number of cases reported this week compared to the last brief. In the DRC, since the last briefing, 1 new health zone, Butembo, has been reporting 3 new cases. Additionally, 2 new recoveries have been reported this week. Cumulatively, 11 confirmed with 4 deaths, with case fatality ratio of 36%, have been reported in 4 health zones in North Kivu province, and 2 healthcare workers are among the cases. This represents a 38% increase in total number of cases reported this week compared to the last week. 8 of the confirmed cases are known contacts, 4 of whom had been vaccinated. To break down by health zones, Bena Health Zone reported 5 cases and 4 deaths. Butembo Health Zone, 3 cases with no deaths. And Katwa Health Zone, 2 cases and no deaths. Museneni Health Zone, 1 case and no deaths. In the Republic of Guinea, since the last brief, 8 new confirmed cases, 3 new deaths, and no new recoveries have been reported in Zarakore, Guinea. Cumulatively, 17 cases with 13 confirmed and 4 probable with 8 deaths, with case fatality ratio of 47% have been reported in 2 regions. 5 healthcare workers are among the cases. This represents 89% increase in total number of cases reported this week compared to last week's brief. So by a breakdown by health zone, Conakry reported 1 case and no deaths, and this case has recovered. In Nizarekore, 16 cases reported and 8 deaths and 1 recovered. 9 cases are currently hospitalized in Nizarekore and receiving treatment. It should be noted that the case in Conakry traveled from Nizarekore and has since recovered. No active case currently reported in Conakry. Just to give you the update of overall response, and DR Congo, as of today, 634 contacts have been listed and 86% of whom are currently being monitored. 856 persons have been vaccinated, and the DRC Minister of Public Health is working with partners, including Africa CDC, in coordinating the overall response in North Kivu province. In Guinea, the general response is, as of today, 490 contacts have been registered, and all of whom are currently under follow-up. To date, 1,489 eligible individuals have been vaccinated, and the Minister of Health also received Regeneron and MAB 114 for the treatment of EVD from WHO. The government has issued a protocol for travelers entering and leaving Guinea and to heighten surveillance and prevent cross-border spread of the virus. In this endeavor, Africa CDC is supported and working closely with both DR Congo and Guinea. And in the Republic of Congo, Africa CDC has conducted an initial need assessment to inform Africa CDC response plan and participated in the development of the Guinean National Response Plan for Ebola virus disease. On March 2nd, Africa CDC participated in an interministerial meeting with ministers of health from Cote d'Ivoire, Guinea-Bissau, Liberia, Senegal, and Sierra Leone to discuss strategies to prevent, preparedness for, and response to AVD outbreak in the region. Africa CDC leadership, led by the Deputy Director of Africa CDC, is visiting the 4 countries, Guinea, Sierra Leone, Liberia, and Cote d'Ivoire. Currently, they are in the field mission to assess and do dialogue and agree on with top leadership in the health sector in these countries on the key areas of support and strengthening response activities and preparedness activities in the affected areas, including neighboring countries. Africa CDC continues to prioritize event-based surveillance and animal monitoring, and we are doing media scanning to support early warning and response within the continent. And we are preparing a technical team deployment of experts into these 4, including affected countries and neighboring, high-risk neighboring countries, a team of experts. Thank you.
Thank you very, very much, Dr. John. Well, colleagues, we've had 3 very powerful presentations today. The first one from Dr. John, then Professor Salim Abdul Karim, and then lastly, Dr. Merawi Arago on the issues of COVID-19 and the Ebola outbreak. It's now time for our questions, so let's dive straight into that. Let's say good morning to Julia of Reuters, and this is Julia Paravicini. And Julia says, last week you said that 270 million doses would be allocated by this weekend, and that you would share the list of countries which received those doses. Can you share it, please? And then she has a second question. Are you negotiating a flat interest rate with Afreximbank for all the countries, or is it variable depending on the borrowing country? Is it 5%, 6%, or what? So she would like to have clarification on that. And those two questions are for Dr. John.
So thank you, Julia. Let me clarify what you are referring to. Last week, I indicated that a first set of vaccines that will be delivered, we are hoping this week, which is the 7 million that the MTN supported the continent to acquire to deliver to support healthcare workers. Vaccination. I think that much is very, very it's clear that we move forward. The 270 million doses, again, let me repeat what I said. I said the orders have in place. That is, the countries have put in their expression of interest for nearly all the vaccines that are the 270 million doses of vaccines. I further explained that what that means is that you have put in the request for vaccines. Then Afro-Exim will use the request now to finalize the agreements with the manufacturers, and then that becomes an arrangement between the countries and the Afro-Exim, and of course us that will provide the vaccines to the country. So it wasn't a question of the vaccines will be delivered this week, the 270 million doses of vaccines. Very, very clearly not the case. So with respect to the interest rate, I would rather than give you information that is perhaps not accurate, you better, I think it would be safe to say that you engage with the Afro-Exim Bank so that they can be very, very explicit with what their financial arrangements are. We are in the AVAC together. AVAC is the African Vaccine Task Team that was set up by the former chair of the African Union. So we are in that together. Our role is to chart the public health direction of where we should be going as a continent, what vaccines we should be acquiring. The detailed negotiations of the financing and all of that is the work of the Afro-Exim Bank. So I strongly encourage anyone who has those questions to address them directly to the Afro-Exim Bank.
Thank you very much, John, for that answer. We have another question or two questions coming your way. And this one is from Alex Winning from Reuters in Johannesburg. And he says, good morning, Dr. John. What do countries have to do to confirm their participation in the African Union's vaccine plan after they have submitted their pre-orders on the AMSP website? And then he also goes on, do they have to open an account with Afro-Exim Bank? And lastly, are there any other steps that they have to take? So those are three questions from Alex Winning of Reuters in Johannesburg.
So very practical questions, Alex. There is various steps that they need to do. One is they open an account with the Afro-Exim Bank, which I think most countries have already expressed the interest for the 270 million doses have done. And at times it's facilitated by the Afro-Exim Bank folks to get them to open the account. And then secondly is that they now have to remain in negotiations with the Afro-Exim Bank for any clarification. I mean, our job is to inform the countries what the doses are on the platform, then link them up into the platform, and then they carry on the negotiation there. So I think that is what it is. We are now in the process of finalizing those contracts with the manufacturers there. So that is all the back-end work that, again, takes some time to finalize, but that work is being done every day. And I mean it every day. Every 8 p.m., there's a task force that comes together to review the progress and advise countries on where they are in the process in that whole process.
We have colleagues who want to ask questions online. Let's start by saying good morning to Girum Chala. Girum, how are you? And please go on with your question.
Good morning, Madam Wayne. Can you hear me?
Yes, I can hear you very well. Please proceed.
Thank you so much. Dr. John, thank you so much. And Mr. Salim Abdul Karim. My questions are two. The first one is in relation with partnership. As we understand, the African CDC has been using lots of partnership platforms to build up its capacity, not only to fight COVID-19, but others. In particular, I want us to discuss about the Chinese cooperation so far. Dr. John, how do you really evaluate the Chinese government government providing for the continent in form of this financing of the construction of Africa CDC HQ?
So, Guillaume,
please zoom.
Yes,
Yeah.
I don't know if I want to be sure that I answer the correct question, because you dropped a little bit there, and I only heard towards the end where you talked about financing and the headquarters. If you don't mind repeating your question. I want to be sure that I'm answering the right question. Yeah, please.
But we can't see you, Doctor. You're off.
Yeah, they are working. They are the back end. They are trying to fix, I think, whatever the technical team is doing. You'll see me shortly.
Yeah. Now I can see you, and then
okay.
We kindly can use this Zoom, because at the end of the day we're going to use this particular footage. So I'm only seeing 3 pictures. Kindly help us, because I don't want us to have a problem later when we share the video. Okay, I can repeat the final question, or I can repeat both very quickly. The first one is on partnership with the Chinese government when it comes to the fight against COVID-19, the provision of consignments and others. How do you really, in general terms, evaluate that, including the provision of vaccines for the continent? Number 2, Africa CDC HQ under construction at the moment. Very exciting for all of us. The Chinese government has provided finance and other things. How do you really also see that? What is China giving Africa in terms of Africa CDC HQ construction?
No, thank you. I think those are 2 very important questions. I would say that the whole premise for global health security or Africa's health security is based on the fact that we have to have trusted partnership with we can do our own things ourselves, but we know that the burden of what we have to deal with is so huge, and as such, partnerships is very important. I always remind myself of this saying, that there's nothing of value in mankind that is done solely by an individual or only a group of individuals. It has to be done with true partnership. So we welcome every support that China and other countries are providing. I think China has been supporting us, Africa CDC, extensively in the areas of diagnostics, in the areas of personal protective equipment, and even the foundations in China. The Jack Ma Foundation was one of the first to step in and gave us, supported us with about 3 different consignments of diagnostics and personal protective equipment. It was just yesterday that I was reflecting on that and sent an email to Jason, who is Jack Ma's chief of staff, on a very personal level, and said that foundation met us at a point of need last year when we were very, very desperate, and I would forever remember that. That was very appropriate and very timely. So I think we value that. And all other countries have supported us since then. They probably had England, the government of the UK, the European Union, the United States, and Canada, the government of Canada, and Korea. The problem with listing names here is that you get into trouble, because you forget somebody's name inadvertently, and then you get into trouble. But I just want to say that we truly appreciate the tremendous support, including from the foundations like the SCORE Foundation, the Bill and Melinda Gates Foundation, Mastercard Foundation, and many others that have really supported us. With respect to the HQ, you know that the groundbreaking occurred last December, and we continue to be very excited with the prospects of that, having our own headquarters, our own campus, and we look forward to the day that we invite you and have this press conference live from the new headquarters of the Africa CDC in Addis Ababa.
Thank you very much, John. We move to our WhatsApp chat, and we have a number of questions actually that have come in from Sarah Jerving, who is with DEVEX, and she has 3 questions. But I think what we'll do is that we'll give the first one to Professor Abdul Karim, and that is the question: what percentage of positive samples do you want countries to perform genomic sequencing on? So, Prof, I wonder if you have a comment on that before we move on to the next 2 questions from Sarah.
Sure, thank you very much, Win. So it's being discussed at the World Health Organization as to what is the minimum benchmark for phylogenetic surveillance. And I think at this point, there isn't a set number. In South Africa, the way we approach it is that we want samples from various facilities that have been designated as sentinel facilities. And from each of those, every month, a certain number of swabs get sent to Professor D'Oliveira's laboratory here. So essentially, we are doing in the region of around 300 to 400 phylogenetic assays every month. So that gives you some idea in relation to our epidemic, what the numbers are. I think it's not so much a threshold. It's important just that you do enough from the various facilities, get your geographical coverage, and ensure that you have at least 1 or 2 samples from each of them. I'll stop there.
All right. Thank you very much, Prof.
And I might want to supplement that as well, to say that what Professor Karim just indicated is exactly what it is. We have been saying on this platform that the sampling framework is very important. And you also have to be able to do that prospectively, because the question is, the fundamental question for vaccines is that variant dominating your pandemic? I mean, in HIV, and Prof. Salim would attest to this, we used to say, know your epidemic. In this situation, we are saying, know your pandemic. And the only way you do that is that you have to sample that over time to really see how this variant is changing. If you use the South African experience, since October last year, and Prof. Karim can speak to this, they saw that the dynamics where this variant change over time and become really predominant. So at that point, you just have no option than to say that, I mean, your vaccine that cannot be used in that population. But if you're sampling, you do in country X, you take a few samples and you see that the variant is there. It doesn't tell you a lot. It doesn't tell you that this vaccine cannot be used in that context there. Just so that, I mean, just to complement what Professor Karim just said.
Thank you very much. Now, the next 2 questions from Sarah. She went on to ask, on average, what percentage are countries currently sequencing? Then her final question, what support is the Africa CDC providing to nations to increase their sequencing capacity? That's for you, Dr. John.
So that's a very good question, Kara. We've set ourselves a target of to produce 50,000 genomic sequencing by the end of the year, and do that using standardized protocols. I think that is one. Second is that we have further strengthened our network of centers of excellence across the continent. And again, I don't want to risk naming names so that I don't get I don't omit certain centers. But let me just, for the sake of this conversation, say that you have centers like the African Genomics Center in Nigeria, headed by Professor Christian Happy, Professor Madou Sall in Senegal, the Nguchi Institute in Ghana, in South Africa, 2 sites are there. We can send you a slide that will show you the whole network of how we are set up to achieve this genomic sequencing. We are providing funding to sites that are ready to, that are already conducting this, including the site that Prof. Karim mentioned, we told you, in South Africa and others. We are providing sequencing materials to other sites, including the machines themselves there. So it's a very extensive network that we have set up, of course, working in partnership with the World Health Organization in Afro. I'm very pleased with that. That is one of the things that, as Prof. Karim said, we started the Pathogen Genomic Institute before COVID. So it looks like we were already well positioned to advance this area of work before the pandemic hit us. So we will keep you posted. Again, take-home message here is that we are projecting to sequence about 50,000 genomes by the end of the year. That we have a series of centers of excellence. And we are also, very importantly, have supported a large number of countries to move their samples, their specimens, to those centers of excellence for sequencing.
11 a.m. meeting. So thank you very much, Prof, for having joined us. We move on with Dr. John, and this next question comes from Lucia Blanco Gracia from the Spanish news agency. And Lucia says, you have said the allocation of the 270 million doses have been done already and the negotiations have started. Do you know when the shipments will start? Also, what about the other 400 million doses that the AU also secured? And then the last question, could you share an exhaustive list of countries that have already started the vaccination campaign? 3 questions from Lucia.
No, sure, absolutely. I think with respect to the last question, which I started off by saying that we do not have the list here today, but we promise you that next week we'll establish a comprehensive list of who has received what vaccines, and it may take a whole session by itself just to give you a list of which vaccines have been received in which country, and how many doses and how many people are vaccinated. We are setting up a dashboard to track all of that. I think that is work in progress, but we'll be happy to share with you. When we announced those doses, the 270 million doses and the 400 doses, there is commitments that have been secured with companies, okay, the various vaccine manufacturers. And that means you have to go through the contracting process to sign legal documents and all the back-end work that needs to go in there. As we said, if you saw that you read the communique with President Ramaphosa, we are still hoping that by the June timeline that some of these doses will begin to come from that process. What is very important, and I really want to make this very clear, is that there are no COVAX vaccines or AVAX vaccines. What we should be looking at is what are we doing as a continent to get to 60%? Okay, that is extremely important for us, so that we also then look at the AVAC, which is the AVDA, the African Vaccine Alliance, to say if Nigeria is close to 2 million doses there, what are we doing to support them to roll that out? Remember, the target is at least 60% of our continent to be vaccinated. It becomes almost irrelevant as to who is giving that vaccine. We take vaccines from bilateral, we track them. We take vaccines from the ADVAC platforms to complement what COVAX is providing. Remember, COVAX is promising to provide vaccines up to, I think, the level of 25%. But if we have to get to 60%, the continent needs to find vaccines. And if we do not get to at least 60% and above, I think it will become very challenging to manage this pandemic after 2022.
Today is coming from Megan Lawrence of Network 24 in South Africa. And Megan says, I have received word from the South African Department of Health that our AstraZeneca vaccines have African Union. I spoke to the media liaison for the African Union in South Africa, who referred me to the HQ or the Africa CDC. Could Dr. John and Professor Karim comment on this? So Professor Karim has left, so that's a question for you, Dr. John.
No, absolutely. If you recall what Professor Karim just stated, that the vaccine didn't seem to work. So let me just give a little bit of history to this. I mean, South Africa had acquired 1.5 million doses of vaccines from the Serum Institute from India. And this is the same source of vaccines that any other vaccine that you are seeing across the continent is coming from the same source, the Serum Institute of India. So South Africa had negotiated a bilateral, obtained 1.5 million doses of vaccines. And just because of the data that you saw a few minutes ago from Professor Karim, showing that the AstraZeneca vaccine seemed to perform less well in that context. It then became an issue of how do we, as AVAC, that is the African Vaccine Acquisition Task Team, get those vaccines, because we are all in a rush to get vaccines to countries. And that is where it became a win-win situation for us, where us meaning the AU AVAC process. So we are in negotiations with the government of South Africa to get those vaccines and then distribute it in countries that do not yet have the issue of the variant. Again, all the vaccines that you heard this week are from the Serum Institute and the AstraZeneca vaccine. So that portion of vaccines from South Africa, we will get it as part of AVAC, and that will be supported by funding from the MTN as their donation, and we'll donate that to countries outside of the areas that the variant is more present.
That brings us to the end of our questions for today. So it's time now for you to just quickly wrap up with the main points that you want the journalists away from today's briefing.
Let me start off with where Prof. Karim ended here. I think I really appreciate that he took time off his busy schedule to explain the variant. And the key message that I would like us to take away is that one is that we can, as we see the trends going down, it is a collective responsibility to continue to ensure that we do the right thing so that we maintain that curve downward. I mean, it means we are not very helpless, that if we continue to apply the public health measures, then the curve will continue to go down. And at some point, the second message is that public health measures alone are not enough. You see the curve go down, and if you look at that curve, the global curve carefully, you see that it's at the very tail end, the curve seems to begin to decide that it will go up there, and that is not a good sign in public health, that in the next coming weeks, you may actually see it come back. So we must be preparing for the potentially the third wave, and unless vaccines are here, and we use them appropriately, we'll continue to be in this wave movement where we come in with the next wave and then we do certain things and lock down economies, which is very destructive. So doing the right things, promoting the right public health messages is the only tools that we have in our hands. My second and last message is that it's all for all of us to provide the right communication messages to our communities that these vaccines are safe, that the variant issue is going to be minimized if we all go out there and get vaccinated once the vaccines are available. And that we know that the variant is predominant in Southern Africa, that other parts of the world, as they receive the vaccines, can part of the continent, I mean to say, can go ahead and get vaccinated, such that there's no miscommunication with respect to whether, these vaccines in South Africa are terribly not good, then there's no reason why Cameroon or Chad or Niger cannot use that because they heard that South Africa is not using it. The science behind why South Africa didn't use their vaccine. And I will rely on the media to also help clarify that as much as possible. Thank you, Wayne.
Before we sign off, I just want to mention something that I heard on radio today, but I think it's something that we can tackle next week. The radio announcers were interacting with their listeners, and they were discussing the issue of the names of these variants. And they were saying that it really gets very confusing. So they were talking about B117, 501, YV2, PIB1128.1, and so on. So the general feeling seems to be that we need an easier way to refer to these variants so that people can understand them without necessarily attaching countries to them. So perhaps this is something that we can discuss next week, because really we've run out of time for today. Unless if you want to make a comment.
I agree with you fully. Let's devote a session next week or in the weeks ahead to discuss that. But there should be a group at the WHO that comes together to provide nomenclature. As you heard me say, we take an exception in attributing a variant to a country, because if we didn't do that with the virus, and it's also not helpful, because it begins to stigmatize people and also stigmatize countries there. The nomenclatures for now are very scientific. I mean, when you hear the N501Y, what does that mean? It means at position 501 in the nucleic acid chain, there's a change from asparagine amino acid to thyroxine amino acid. I'm not sure this even helps at all, because it's still a lot of jargon there, but just to tell you that is what it means by the N501Y change. It just changes in amino acids from one form of an amino acid. And if that change occurs, then it defines differently how the virus binds to your cell. If the initial amino acid there on that protein was asparagine, and it changes to thyroxine, it may completely change the way the virus sees your cells. That is all it is. But we can have a different discussion at a different time.
All right, I'm glad to hear that, because I think the ordinary people on the street would really appreciate knowing how to identify the different variants. But for now, let me thank you very much, Dr. John Nkengasong, the Director of the Africa Centers for Disease Control and Prevention at the Africa CDC, Professor Salim Abdul Karim, who is the Director of the Center for the AIDS Program of Research in South Africa, who is also co-chairing the South African Ministerial Advisory Committee on COVID-19, and is also a member of the African Union's African Task Force on Coronavirus. Let me thank lastly, but not least, Dr. Merawi Aregao, who is the Incident Manager for Ebola for the Africa CDC. Thank you all very much for being with us. Thank you for the team behind the scenes that made this possible. We will meet again next week on Thursday at the same time, and that is 11 a.m. East African time. Have a great week.
Thank you.